What does this all mean for the future? So when we think about the research, what do we need to go in the research? One of the challenges we have all the time is the evolving pattern of long-term and late effects. So I'll give you an example of that with the introduction of the aromatase inhibitors. We're now seeing all of these complaints about the arthralgias, the pain syndromes in our breast cancer population, and in some cases women saying, I'm not going to take these medications because it makes me too uncomfortable. So it's trying to chase the science sometimes about what are the new toxicities that we have to be screening for and addressing going forward. And as I said before, this opportunity to explore psychosocial and behavioral interventions to promote health and adaptation, a large window of opportunity for us as we return people into the community. We certainly also need to be looking at the family caregiver impact. This is a direction that the NCI is going to be pursuing. Trying to examine interventions that may help the caregiver cope, but as a consequence also help the survivor do better. Looking at economic outcomes and patterns or models of care, as I said earlier, is very important. Where should this care be delivered? How is it going to be most cost effective? Who needs to be providing this care? Can we have different levels of professionals? Cancer communication is going to be a backbone in all of this, as you will see in a report that I'll describe in just a second. Instrument development. We have wonderful instruments now to assess patient-reported outcomes during active treatment. Our challenge is to grow these so that we can explain patient-reported outcomes post-treatment, the new kinds of problems that patients have that may be different than those during the acute phase, and also measures that allow us to compare individuals with a cancer history with those with other kinds of medical conditions. So can we say, is the burden different for someone who has cancer versus someone who doesn't carry that diagnosis? Certainly the aging and cancer interface is staring us in the face. We really need to be thinking about that and what the implications of that might be. And then doing all of this work in our neglected groups of racial and ethnic disparate income, location, rural, suburban, urban, etc. In terms of the intervention research, what we're seeing moving very quickly is screening for those at risk, targeting and tailoring interventions, not just doing one size fits all, appreciating the role that education plays. We've gotten such complex care now. Our treatments are so complicated, and the length of stay in hospital is de minimis for most individuals. So actually educating individuals about their cancer and treatment is an enormous challenge for us. And how to deliver that is something we constantly revisiting. How do you communicate that? What platforms do we need to do that? Who needs to do it? How often do we need to be doing it is really a big challenge. And in that process is looking at peer support, because sometimes these are wonderful vehicles for us to actually get across that information with appropriate training, but extends our opportunity to communicate using that population. Certainly, as I said, we need to look at new technologies, the internet, personal digital assistants, telephone, teleconference, all the new electronic ways we have to really extend our reach. I'll give you an example of one of these. The NCI collaborates with Cancer Care and a couple of other partners. The Lance Armstrong Foundation also helps support this. The Intercultural Cancer Council, Living Beyond Breast Cancer, and the National Coalition for Cancer Survivorship. We do a teleconference series every spring. We do three one-hour programs that will run starting this month, so April, May, and June, on survivorship topics. This could be on talking to your physician about follow-up care, on sexual functioning after treatment, on depression and fatigue after treatment, etc. We can, on these calls, in the last several years, register up to 2,000 people on these calls. We've had over 26 nations represented in the individuals who are participating. The reach of that technology is phenomenal to actually get evidence-based information out on those programs. So I personally am very excited about the capacity we have to leverage these kinds of technologies. And certainly one of the challenges we also have in our intervention research is we often fail to look at the health outcomes or health utilization attached to this. So we have a broad range of psychosocial interventions that we know are very helpful for individuals in how they cope with their illness, their functional well-being, specific kinds of side effects that they might have with their treatment. And very rarely do we have cost data to tell you how expensive would it be for you to run this in your clinic or your program or your practice. So it has really impeded us in being able to translate this research back out into the community because we don't have those cost factors for you. It is a gap in our research, and it's something that we need to correct right away.